Started. All right. I'm pleased to introduce to you today Dr. Bruce Dalkin. He is a board-certified urologist and a UW professor of urology. He evaluates patients with suspected problems, educates them about treatment options, and, when required, provides the highest quality surgical treatments. Dr. Dalkin strives to provide current, accurate, and thorough information to patients in a way they can truly understand to enable them to comfortably decide about their urological treatment. And he's here today to talk to us about urology for geriatricians, common clinical problems to address. Thanks for being here today, Dr. Dalkin.
My pleasure. First, let me just say that this is Nurses Month. I know that many of you are nurses, so I want to thank you for your contributions. And when she asked me to give this talk, I thought, what is it that sets, in my opinion, nurses aside? I've had very good fortune of working with tremendous nurses over my career. Initially in Arizona with Jan and Gloria, here in Washington with Danetta, and probably the greatest nurse in the history of the world is someone named Darla Schaller, who worked with me for a long, long time in Tucson and then moved to Bellingham, interestingly enough. So she's probably still there. But what sets, I think, nurses, exceptional nurses aside, is their ability to do clinical decision-making. Empathy, compassion, technical things, those are all critically important. But if you can learn the disease entities that you're taking, for which of the patients you're taking care of, and then assist in making decisions, that's really, I think that's an exceptional role. So what I tried to do today was to give you some education about common urological diseases, to try to expand your fund of knowledge, and then sort of see how we think about these things, which will help you in the care of your patients. And I had never seen the 4 M's before, but I do think we actually will hit on all 4 of them. So we'll get going. So I want to cover these 7 topics: benign prostatic hyperplasia, prostate cancer, kidney masses and kidney cancer, bladder cancer, urinary stones, hematuria, and the always painful urinary catheters. So first, let's start with the most common problem that we see, which is just avoiding trouble in men. And I think when we see these gentlemen, there's a number of things that we have at our disposal to help ascertain what's really going on. In terms of the history that we take, I'll show you something called an IPSS form in just a second. It's this little form with 7 or 8 questions that they score to say how problematic their symptoms are. And it's divided into 2 components that will cover: obstruction and irritation. And one of the other things that's very important is how much do these guys drink, and we'll talk about that. Men complain about waking up at night to sleep, and is that related to having to pee? Is it sleep habits? Is it how much they drink? We'll touch on that. And then we always ask about blood in the urine and urinary tract infections, because these can be underlying symptoms related to those problems. When we see these people in the office, prostate exam is really mandatory. We're looking for prostate cancer. We're looking for prostate size. When we examine their abdomen, we're trying to feel if their bladder is distended. Many of you probably have offices that have bladder scanners. Those are routine things done in our office and in many primary care offices to check how well they're emptying their bladder. We have these little flow rate machines that measure how good or bad your stream is, and I'll show you some of that as well. Basic laboratory testing, urinalysis to look for blood or infection. We'll talk about prostate cancer screening at length, but in general, if men present with urinary symptoms, a PSA is important because cancer is on the diagnosis and you can't ignore that. And then, of course, if they have a very high residual, we worry about their kidney function. So let's move forward and we'll touch on all these things. So this is an IPSS score. And if you just look at the highlighted words on the left underneath over the past month, it's questions that relate to incomplete emptying, urinary frequency, how steady is your stream, do you get a lot of urgency, how weak is your stream or how strong is it, do you strain to pee, how many times you wake up at night to urinate, and then you go from 0 to 5, 0 meaning you're not bothered at all, to 5 means you're miserable. So this, you add them all up and you get a number between 0 and 35. And you can see if you go below the first chart that we call these mild, moderate, and severe. 1 to 7 mild, 8 to 19 moderate, 20 to 35 severe. Now, I must tell you that although it looks objective, there's a lot of subjectivity to this. And there's also some interpretation problems with this by many men. So although it's one of our objective criteria, that you got to be a little careful with how you use it. And the last question on the bottom is sort of, how much are you bothered? We call that a bother score. Are you terribly bothered, which would be a 6, or are you delighted and not bothered at all? And this is really pretty much everyone that comes in with symptoms fills this out. It's sort of the mainstay. It's also used to see how medications help people or they don't help people, how surgery helps people. You look at comparisons of before and after. Now, here's an example of a flow rate. And I have my little pointer here. And this is actually 2 different 70-year-old men. And I apologize for the little bit of goofiness here, but this is a curve of, they pee into this machine, and when the urine flow starts, this is the flow rate in cc's per second. So 20 cc's per second is where this man peaks. This man peaks at 7 cc's per second. And then if it goes up quickly, that's good. And then you finish quickly. Here you can see that it goes up a little slower and it just sort of takes a long time to empty. And we look at certain things like how much did they pee? If you pee 300 cc's, that means that's a good study. This one is 204 cc's. That's actually pretty good also. But this is an example of a guy in his 70s who's in the top 1% of voiders for his age. And this is a guy who's in the really bottom half. The peak flow rate for 70-year-olds average is 10. For a 30-year-old, it's probably 50. So you can see that, as with like most things, it goes down with age. But I wanted to show you, these are the flow studies. And then you combine this with the post-void residual. And that's how we look at those objective endpoints. Now, I think one of the most overlooked entities for primary care, although you have so much to do, I'm not being critical of not asking these questions, but you'd be amazed at how many elderly men do these things that really are the root of their problem. Bladder irritants, coffee, tea, soda, spicy foods. These are all terrible problems as you get older. Your bladder capacity goes down as you get older. So whereas you used to eat all this stuff when you were 30, it's going to be more of a problem for your bladder, and it's more irritable if you're 70. And many of you have heard people say, oh, you got to drink a lot of liquids, you don't want to be dehydrated. Well, if you ask a 70-year-old to drink 3 or 4, quarts or liters a day of fluid, they're going to be peeing every hour. So a lot of times it's just volume. And the nighttime waking up, a lot of times it's just drinking before they go to bed, or they get up at night to pee and they drink a 12-ounce glass of water. These are little subtleties in history that really help. And really 30% of guys that I see in the office, it's just these modifications will solve the problem. Obviously, diabetics who have poor diabetic control, or people that use diuretics, these are all things that impact on frequency and urgency as well. And in the post-void residual concept, this is usually that little bladder scanner. Many of you are familiar with that. It's not perfect. It's been shown that actually, if you want to get an accurate assessment of someone's bladder, you have to do it 3 different days. And it does require some technical skill, so you can not do it well and get a bad number. In general, when we look at these numbers, there's nothing black or white about them. I mean, if it's under 200 cc's, that's usually pretty good. If it's 200 to 400 cc's, that's something to be concerned about. If it's over 500 or 600 cc's, they're basically in retention, whether they know it or not. And those are people that really need to consider bladder decompression. I think the most important take-home point here is that these numbers we don't do anything based on, with the exception of numbers over 500, we don't do anything based on a number, but they do correlate with the future of this gentleman's voiding patterns. In other words, if they have a high post-void residual, they're likely to get into more trouble in the near future and end up having some procedure. If you don't have a machine in your office, you can actually order this through ultrasound it's just called the bladder ultrasound pre and post void. So it's really pretty simple. But again, another objective piece that we use to help in decision-making and see in response to treatments. And I think that the medical management of this can certainly be done through probably should be done through a primary care office. In general, the best medications to use are the alpha blockers. There's a lot of them. I just listed two. In general, they're taken at bedtime, although alfuzicin can be taken anytime. The reason for that has to do with getting dizzy if they take it, then they're in bed. In general, by 4 weeks, if you're not better, it's not going to help. I think the most important thing here is there was a big study called MTOPS years ago that looked at this medicine with or without finasteride or Proscar, which we'll talk about in a second. And just so you know, the average improvement in those symptom scores, that score that went from 0 to 35, was 6 or 7 points. And the placebo was 4 points. So don't expect miracles. Some guys will be dramatically better. But in general, they can be better, but it's not going to be, night and day. In general, if they're not better with the Flomax or alfuzicin, you can add Proscar. In general, that's for people with larger prostates, which you probably won't know because you're not routinely doing rectal exams, which is fine. But it can take up to 6 months to see the benefit. And in this MTOP study, the two drugs together were better than either drug alone. So sequentially is probably the way to do it. There's also use of anticholinergics or these beta-3 agonists, which are called maravigon. We'll talk about in a second. These are really drugs for men who have urgency incontinence or just urgency. And in general, that can be due to obstruction. And if they're emptying their bladders pretty well, using these medicines is safe. If you have someone who's not emptying their bladder well and you put them on an anticholinergic or maravigon, you may put them in retention. So you sort of have to have some assessment of their residual before you use them. But we use them frequently in men with low residuals and a lot of irritative symptoms like urgency. Parkinson's disease, obviously you have to be careful about the use of anticholinergics or maravigon. That changes every couple of years. I would say you have to check with the pharmacy as to or their neurologist as to what they consider to be safe. So these are all medicines that can be dispensed before we see them, but we're happy to do it. But I would say always give the alpha blocker with or without the Proscar first before we see them. And these are the different bladder relaxing medicines. I mentioned the anticholinergics. I'm not going to go into all these, but there's 3 basic groups. There's anticholinergics, the names of which you see there. This Detrol, Vesicare, Sanctura, and Nablix, they tend to have less dry mouth and constipation than Ditropan. Equal efficacy. So a lot of people skip Ditropan and just go to one of these. Antidepressants like imipramine, desipramine, these are actually for men who have urgency incontinence because they relax the bladder and tighten the bladder neck. So men or women really in that situation, you may make it harder for some of these guys to pee if it tightens the bladder neck, but they're usually on Proscar or finasteride. I'm sorry, Proscar and or Flomax as well. So their bladder neck is subsequently being relaxed. But urgency problems are good for this. These are the newer drugs: maravigon, Vevron, Gemtasa. Very expensive. They work great. They have less side effects. In general, if the less expensive drugs work and the side effects are bad, then the patient can decide whether they want to spend the money. The price of these will come down. A lot of urologists are using them first line, but I would say start with the standard drugs up here. And if those work or don't work, then you can go up to here. Now, for those men that really have symptoms refractory to medication or other serious sequelae to BPH, we end up doing outlet procedures. And these are basically procedures that open the prostate channel. They're not removing the prostate. They're just creating a wider channel to pee through. Now, there are certain presentations when people really go first to surgery. For instance, if they're on alpha blockers and they go into urinary retention, there's no drug that's going to help that. So those are people that really need a procedure. If a man presents with high post-void residuals, elevated creatinine, and hydronephrosis, they have something called obstructive uropathy, meaning no matter how they feel, their outlet is causing them renal damage. And those people will not be solved with medication. So they need to go to an outlet procedure. People who have bladder stones and don't empty their bladder, men, there's a few of these that don't need outlet procedures, but most do. If they have recurrent infections because they're not emptying their bladder, that's another indication for surgery. And lastly is gross hematuria due to benign prostatic hyperplasia. So these are men who've gone through hematuria evaluations. They don't find a cause other than prostate, and it keeps happening again and again. That said, though, the most common indication for surgery is symptoms that are not responsive to medication. And this is a totally reasonable approach if the patient wants to go through it. And there are some that are benefited by the medications, but the side effects are not tolerable or the cost is too high and they would rather have a procedure. And there's lots of different procedures. I won't belabor this too much, but the ones that are more commonly done nowadays, transurethral microwave should be in the garbage can. Urolift, if you watch any television, you'll see this advertised on TV. It's actually no better than medication. So it won't make you any better than Flomax or alfuzosin. If for some reason that medicine helped you and you don't want to take it, it's a good procedure, but it doesn't do any better. There's some water jet things that are happening now that will be interesting. Resume has been around for a while. This is a heating system that's actually in the short term been comparable to the ones below it that we'll go over. It does give you a little bit more bladder irritation for about a month, and we have to leave a catheter in afterwards for a little bit longer. But it's on the list now and pretty reasonable. The standard ones with a durable track record are standard resection of the prostate. There's 2 good laser vaporizations, which actually remove tissue. That's a green light or Revlix. And there's something called HOLIP or SOLIP. Those are enucleations where you just take the prostate out, you push it into the bladder, and you morcellate it in the bladder, and you suck it out through a little suction machine. They're very good procedures. They're a little bit technically more difficult, and not many urologists do them, but they really have excellent results. Any of these, they all have comparable results if they're done well. That's really the key. And then for people with super large prostates, that it's too much tissue to remove through telescopes in the penis, they're stuck with either an incision and open enucleation, or we can do that robotically. Those men actually end up with the best results after procedure. But it does require a little bit more involvement in the recovery. What are the risks? I think there's some of these that are very pertinent for geriatric patients, not necessarily this first one, where they do lose their seminal emission. So if they have ejaculation, no fluid comes out. They can always get scar tissue or it can regrow. Those are relatively low numbers. There are certainly 15 or 20% of men that won't get better. And that relates to the fact that we can't really prove in 100% of guys that their symptoms are related to obstruction. Or the surgery wasn't done well. Long-term incontinence is rare, but it's much higher in poorly mobile or debilitated men because their access to bathrooms isn't quite as quick. We worry about anesthesia, obviously, in the geriatric population with problems with delirium. Although this has been shown to be safe in octogenarians who are functioning well. If they have any existing cognitive deficiencies, problems like Parkinson's, they have catheters in their bladder, they're bedridden, these guys are not going to do well. So we're very hesitant to consider interventions in that population. So that's pretty much the nuts and bolts of BPH. Now, prostate cancer for a geriatric population is a little bit different. I'm going to try to run through the basics for all age groups, and then I'll try to focus my time on looking at elderly men. So these are just some of the pearls. As you know, PSA screening is really no longer done through primary care, and that's a whole different discussion. And it's correct, certainly for a geriatric population. But in general, the population of men, historically, the PSA screening, where they come in for their annual physical and they get a PSA test, are men who are supposed to live 12 to 15 years or longer. That's the group where prostate cancer mortality did decline back in the late 80s and 90s when PSA came out. but that comes in with urinary trouble, weight loss, and PSA testing should be done. You're not going to be related to prostate cancer. In general, if a man is diagnosed with prostate cancer and they're not supposed to live more than 8 to 10 years, it's unlikely, that's based on their age and health, not prostate cancer. It's unlikely that any of the aggressive interventions like surgery or radiation are going to be helpful. And we'll talk about how we manage these people with something called watchful waiting. You'll frequently hear people say, well, he's too old for radiation, too old for surgery, he should not have radiation. I'm sorry, he's too old for surgery, he should have radiation. That actually isn't true. Either you need to be treated with one of the two or not. There are some elderly men, though, who can't stand not being treated. And in that scenario, radiation is safer than doing a surgery. But as a routine, that's not a good recommendation. And lastly is, in general, when we talk about radiation versus surgery, radiation in any form, external beam, seeds, whatever, it's really the men under 65 who are healthy where the surgery has been shown to have better long-term cancer control than radiation. Now, most men diagnosed are 70 and older. So in general, that population, we don't tell them that they'll live longer if they have an operation. But in the younger population, the majority of them are leaning towards surgery. Now, the whole issues of what are the quality of life changes with radiation surgery, they're significant. I'm not belittling them, but that's another 1.5 hour discussion. So we'll save that for another day, maybe. And then when someone's diagnosed with prostate cancer, they're put into these different risk groups. I'm just going to say that high-risk disease in general will result in a patient's demise within 10 years. Low-risk disease is usually well treated with surgery or radiation in those that need treatment. And intermediate-risk disease certainly doesn't do as well as low-risk disease. And so we struggle with this concept of active surveillance we'll talk about in a second. But in general, intermediate risk disease is treated because it can impact on you in the next 10 years. High risk disease is treated, but treatment doesn't usually work, as you can see there. What you've heard about, what you'll hear about recently in the past 7 or 8 years is something called active surveillance, which is men diagnosed with low risk cancer, as you see above, and not treated, but just watched. And they're watched with serial PSAs, exams, rebiopsies. And if they get worse, in other words, they become intermediate risk, we treat them. And the purpose of this is to maintain your quality of life. You're not having radiation, you're not having surgery. So if you have a good quality of life, then that's not going to be compromised. We have learned that the reclassification rate at 5 years is about 50%. And by 10 years, it's going to be 80, 90%. What we're struggling with right now is the fact that we don't know if waiting to treat a young man with low risk disease 5 years later when he has intermediate risk disease will provide him the same 15, 25-year survival as if he'd been treated right up front. And the studies that we're doing may not answer that question because you have to follow people for 20 years. So if you have a healthy man under 60, 65 with low risk cancer, it's a very reasonable option to do active surveillance, but you need to offer them some treatment because that unknown may end up impacting on them in the long run. In some of our guidelines, active surveillance is recommended as a preferred approach, but they're not really subclassifying based on the age of the patient. So in a young man, you got to be a little concerned. Watchful waiting is really what you'll see in the octogenarians or the unhealthy men over 70. This is really the concept that hopefully you'll never need to do anything, even if they have high-risk cancer. And it's based on using something that lowers testosterone or androgen deprivation therapy. The basis of this is that if you give androgen deprivation therapy in 2020, or you give it in 2022, they live the same amount of time. I'll show you a little graph. So in general, early is the same as later, although that's counterintuitive, it's true. So what you're doing is watching guys and hoping you never need to do it. But if they get worse, then you can start on hormone therapy and you haven't shortened their life. And here's sort of an example of on the left of your screen here, you see they're diagnosed with cancer. If you give them hormone therapy right away, you can make things better. Hormone therapy is not curative. So if they live long enough, they die here. If you don't give them hormone therapy, they get worse. You treat them and they live the same amount of time. But you have this period of time here where you're not on hormone therapy. And the hormone therapy has been shown to certainly cause side effects or problems. And, this is just an example. It lowers your testosterone. There's a lot of different ways to do it. There's shots, there's removing the testicles. There's actually an oral pill that can do it now too. There's a second drug called bioclutamide or Casodex that you might hear about that's given for the first month of treatment to prevent the testosterone from going up. And there's all sorts of newer medications, abiraterone, enzalutamide. There's 7 or 8 of them. This is a rapidly evolving area because there's lots of money to be made. And the newer medications actually are now given fairly standardly, either right up front or certainly when they fail the primary shots or orchiectomy. And they've been shown to prolong survival about 12 to 18 months compared to the past. The average survival back in the early 2000s, mid 2000s was 2 years, 2.5 years, and now it's 3.5 years. So it has been a good contributor to survival, but very, very expensive. If you look at the cost per adjusted life year, it's over $500,000. So that's pretty pricey, but commonly used, and as I said, very helpful. So from a seniors population standpoint, those are really the main issues related to prostate cancer. So let's get into kidney masses, because you're going to see this commonly. 10% of the population have a kidney cysts or kidney masses. The way we look at that is if you ordered a radiology study, whether it's an ultrasound, a CAT scan, an MRI, and you see these things, they're given Bosniak criteria for renal lesions. And they give a number 1 to 4. So 1 is a simple cyst, very common. You don't have to do anything about it. They rarely, if ever, cause any problems, even if they're big. A Bosniak 2 is a cyst with maybe some subtle irregularity, but of no concern. They have a new category called 2F. F stands for follow. That means that you probably should retest these every couple of years because there is some risk. Although there was just a recent publication that showed that the likelihood of developing a problem in the next 8 years was less than 5%. A problem meaning either a solid or clearly solid lesion, which is a Bosniak 3 or 4. So the Bosniak 3 and 4s are the ones where there's a high likelihood of cancer. And those are the ones that usually will intervene upon if the person's healthy. Now, for the solid masses, there are 2 non-cancerous solid masses. One's called an angiomyolipoma and the other's called an oncocytoma. These are actually relatively common, and angiomyolipomas are pretty easy to ascertain on CAT scan or ultrasound because they have fat in them, which is unusual for renal mass. Oncocytoma is not so easy. Biopsy is fairly accurate, so you might see some renal masses recommended to have a biopsy by a urologist. That's really trying to ascertain if it ends up being benign. You don't have to do anything, like an oncocytoma. And there are some where the type of kidney cancer may be helpful, because as I said, there are many different subtypes. I just listed a couple of them here. Most commonly is something called clear cell, but we've subdivided them, which helps predict prognosis. It doesn't really change anything that you would do up front. So that's ultrasound or MRI or CT scan imaging and what to do with that interpretation. Now, in general, as I said, benign lesions can be followed. Some angiomyolipomas, when they get big, they can bleed. And so they can be embolized by interventional radiology. So we do follow them. For malignant masses, which are solid and localized, biopsy, not always done. We look at the size and the location of it. In an elderly population who have a projected survival of less than 7 or 8 years, there's no reason to treat a small renal mass. It's been very well shown that these will rarely spread in 5 or 7 years. So in general, surveillance is the recommendation. My neighbor has their yard being fixed. So give me 1 second and let me close the window. Okay. So as I said, surveillance is very reasonable. You may image it every year or 2 years just to keep an eye on it. If someone's adverse to being watched, there are ways to sort of minimally invasive treat these. We can freeze them with cryotherapy, which can actually be done in a CT scanner. or we can do it through a surgery. Major interventions like taking out part of the kidney or the total kidney for cancer are the standard effective treatments. The robot's been very helpful in doing partial nephrectomy. In general, for lesions less than 7 centimeters, most people are getting a partial nephrectomy. It's been shown to be comparable to total nephrectomy in terms of cancer survival. We used to think that removing part of the kidney would help prevent renal failure, dialysis, vascular issues, but it actually doesn't. In general, it's their underlying medical problems that cause renal failure, whether they have 1.5 kidneys or 1 kidney, it doesn't really matter. But because the technique of partial nephrectomy with a robot has become so standard, most people are having partial nephrectomies unless it's too hard a lesion to do that way, or they have lesions in both kidneys. They might get 2 partials or 1 total and 1 partial. So there's some variables in play there. But don't be surprised if someone
You're a little frozen, Bruce, but hopefully you'll come back like you did the last time.
recommends surveillance intervention in someone else, and primarily a younger person, we really have nothing to offer. Sadly, hoping that would help. But it turns out it really hasn't helped at all. So we stopped doing called cytoreductive nephrectomy, unless you're on some type of study. There is a curative treatment for metastatic kidney cancer. It's called high-dose interleukin-2. Most people can't tolerate it, and it really only has had 2% cure rate. So you'll almost never see that used. And there's a lot of pills and things that we have. Most of those end in IB, which are some of the newer medications, sunitinib, sorafenib. They may extend life a couple months, but they're not really curative. And rarely you'll see people with metastatic cancer that may live 5-10 years because they have a sort of a natural history of a very protracted course. But that's the exception to the rule. Most of these people pass away within a year or two. Bladder cancer, pretty common. Common symptom is gross or microscopic hematuria. Sometimes it includes irritative symptoms. Smoking and solvent to dye exposure are sort of the 2 big risks. Obesity is really another one. When we look at these tumors, when we remove them, it's really 2 groups now. There's high grade and low grade, and there's superficial and invasive. We have these different T stages that we give them. I won't get into that. We'll talk about that in a second. Our job is basically to remove these in the operating room endoscopically through telescopes in the penis and get an accurate grade and stage. And then that dictates where you go from there. So in general, for people with low grade, non-invasive tumors, they're not they're not threatening to their life. They commonly recur. All these people will be on surveillance, which is an office cystoscopy. Occasionally we'll use intravesical therapy or put medication in their bladder to try to prevent them from getting frequent recurrences. The common drug there is called gemcitabine. For people that have high-grade disease that is non-invasive, again, they rarely progress to life-threatening tumors, which are the T2s. We'll talk about that in a second. But they commonly recur. So again, close surveillance. And we might use a different medication in the bladder called BCG, which is that attenuated tuberculous virus. The ones that start to be really a risk are something called high-grade T1. High-grade T1 is high-grade, but it's growing below the skin surface into the submucosa. And these are men where over the course of the next 15 years, they're in deep trouble. About 15% of them at 5 years will progress to life-threatening or T2 cancers. But by 15 years, it's most of them. So these are people that we follow very closely. We use BCG, we other medications, hoping they don't progress to T2. The last sort of disease that we see on biopsy is something called carcinoma in situ. You hear about this in cervical cancer too, but for bladder, it's a high-grade disease of just the mucosa. And these are people that have recurrence almost guaranteed and progress to T2 at the same rate as the high-grade T1s. So we use BCG primarily in this group, but they're also at high risk for developing life-threatening cancer over the ensuing 15 years. Now, that said, for men presenting in their 80s with high-grade T1 disease or carcinoma in situ, the odds of them actually becoming life-threatening over the next 5 years is quite low. So those people can be safely observed. And I've had patients who are in their 80s with carcinoma in situ where you just stop doing anything because nothing's worked, and they end up not dying of bladder cancer. So a lot of this depends on the age and health of the person, obviously. Once they develop cancer that goes into the muscle wall, those are the ones that really are life-threatening. As you can see, with no treatment, the odds of living 3 years is about 5%. These are people that get gross hematuria, pain, kidney obstruction, urinary retention. The primary treatment is really bladder and prostate removal in men and bladder removal in women. Unfortunately, the cure rate is not super high, 50 to 60% at best, sometimes up to 75%, depending on how they present. Neoadjuvant chemotherapy, it's become a standard to recommend chemotherapy for bladder removal. This is a classic example of maybe overshooting the mark, but it does have a 5% survival benefit, but that means that really only 1 in 20 patients are benefited. It's become the standard of care. That's what SOC stands for. But if there's someone who can't have chemotherapy or is chemotherapy averse, it's okay, because he's got a 95% chance of not being harmed. So just keep that in mind. It's been shown that it's rare that chemotherapy will then lead to an inability to do surgery. So that's been pretty clear. And it's also been shown that delay to surgery by giving chemotherapy hasn't resulted in harm in terms of cancer cure rates. So that's essentially why it's being used routinely. You'll see it done at universities more commonly than in non-university settings, really because universities tend to follow guidelines. And this guideline is out there, but it's, as I said, it's only 1 in 20 men benefit or women. There is another regimen called bladder salvage, which if you can't have your bladder removed either for health reasons or because you say forget it, we do use radiation with chemosensitizing agents. In general, this won't work at all unless you have a very small lesion that we shave out and we think we got it all out, but it is in the muscle. But of course, if you're unhealthy and you can't have your bladder removed, this is how we do it. Even in elderly people, it's usually well tolerated. The chemotherapy is single dose, single agent, multiple doses, so it's not terribly toxic. And then for metastatic disease, the cure rate is only 5%. And that's why it's really hasn't replaced surgery for healthy people. Half of them may respond, but at 2 years, 95% have recurrent cancer. And there are some new immunotherapies out there, pembrolizumab and enfortumab, that are now FDA approved. Now, that doesn't mean that they're actually that good. It just means that they can be tolerated. So you might see them in conjunction with chemotherapy now, or in people where chemotherapy doesn't work. They add a few months to life, but cure rate is rare. Now let's get into the common things, stones. So in an elderly population, many stones don't need to be treated. So the mere presence of a stone doesn't mandate treatment. Then that's what I mean by that as a kidney stone, not a ureteral stone. If the kidney stones drop into the ureter, then you have to treat them if they don't pass on their own. But even kidney stones that are too big to pass, 7, 8, 9, 10 millimeters, they don't have to be treated. If you make it to 80 and you have a kidney stone that's 9 millimeters, so what? But in general, when they drop, if they don't pass, and we'll get into that, then we'll treat them. But don't let your patients, your 84-year-old man with a 7 millimeter kidney stone, have to have surgery for his kidney stone. Septic stones are clearly a surgical emergency where the person comes in with a fever, apparent urinary infection, and an obstructing stone. But they have to have drainage of their kidney, either with a nephrostomy tube, or we take them to the operating room and put a stent in their, up through their bladder into their kidney. You can't sit on these people overnight. It's a 50% mortality if you don't do anything right away. Then usually we'll drain their kidney and come back in a couple of weeks and treat the stone, and we'll hopefully get all their tubes out. Beware of, quote, symptomatic, unquote, kidney stones. So patients come in and they're having flank pain and they have a small stone in their kidney. They can cause pain, but we're always careful that if we remove that stone, we can't promise you your pain will go away. Now, if they get to be big, like 2 centimeters or bigger, then it's more feasible that they could be causing pain as they bounce around. The little ones shouldn't. And we really decide on the type of treatment based on the size. So if they have stones that are less than 2 centimeters, we usually will look up from their bladder and use a laser. If they're big stones, greater than 2 centimeters, sometimes they have to have a tube put in their side, and we look in through the side and break up the stone that way. So that's a major intervention. For stones that are in the ureter, ureteroscopy is really still the primary treatment, meaning look up the ureter and use a laser to break up the stone. ESWL or lithotripsy is totally reasonable. It's still done not uncommonly. As long as you can see them on ultrasound or with whatever imaging guidance system you're using, and they're less than 1 centimeter. The advantage, of course, is you don't have to be asleep. It doesn't quite have the stone-free rate as ureteroscopy, but in someone who's averse to uroscopy or stents, it's totally reasonable. Now, 2 other little factors that are important. If one of your patients has a stone in the ureter, almost everyone is getting medical expulsive therapy, which is Flomax. It's thought to help relax the ureter to help the stone pass. It turns out we're not sure it does that. I mean, there's good studies from Great Britain that show that at 1 month, same number, there's equal passage of stones, whether they were on Flomax or not. The question was, did they pass them quicker on Flomax? So in this country, it's really standard of care. If you're in the ER with ureteral stone, you should go home with Flomax for 3 or 4 weeks and try to help you pass your stone. I think it equally as important is what do you do with someone who's had a stone and you've treated it or they pass it? There's actually a very we do metabolic evaluation, and the goal here is to prevent future stones. Now, obviously, dilution, the solution to pollution is dilution. So you tell people to drink a lot and that helps prevent stones. But as I alluded to earlier, that can be a big problem in the geriatric population because you're then making them pee every 30 minutes. We try to analyze the stone if we capture it or the fragments that we treat to find out what kind it is. And then most people, if you're younger and you have your first stone, you definitely should have a 24-hour urine collection for things like calcium oxalate, citrate, uric acid, to sort of find out why are you forming a stone? Because in most of those people, there's a correctable problem. Whereas if you're 75 and you're having your first stone, it's unlikely you have a metabolic cause. So in general, that's reserved for the younger patient with their first stone or someone who's had recurrent stones, no matter what their age is. And if you're going to keep an eye on people with kidney stones, normally they're imaged every 1 or 2 years. Ultrasound is not that good. The problem with CT, of course, is there's radiation exposure. So if you're going to do this for a long time, it's a bit of a problem. Most have a limited renal CT protocol for stones, so they don't get as much radiation. But in general, that's sort of urologist discretion, whether it's every 1 year or 2 years. And then if the stone is enlarging, then you might get it treated. So that's sort of the medical concepts for evaluation and medical therapy. Now let's get into gross and microscopic hematuria. So I think one little take-home point is that gross hematuria due to an infection is very common in women, but it's very rare in men. So if a man presents with gross hematuria and a urine infection, they're probably true, but unrelated. So that man needs evaluation. Whereas if a woman presents with an infection, gross hematuria, if their urinalysis a couple months later and repeat culture is negative, they really don't need anything further. Now, the only exception to that may be an elderly person who's a heavy smoker, but in general, those people will get recurrent hematuria or they'll have microscopic hematuria and they end up getting evaluated. But in men, like I said, even if their culture is positive, we need to see them. So when we take a history in people with hematuria, we're looking at whether it's at the beginning of the stream, the total stream, or the end of the stream. That helps us to predict sort of where the site is. Do they have a history of stones? Do they have urinary problems? Are they smokers, or do they have solvent exposure, which are the 2 bladder cancer risks, as I alluded to before? And our basic evaluation is a basic metabolic panel urinalysis with microscopic and culture if needed. We don't routinely do voided urine cytologies in hematuria patients because you'll see why in a second. And if they're having urinary trouble, then we check a post-void residual. The standard imaging for these people is CT-IVP, which is a CAT scan with injection where they do delayed films to show the ureters and the bladder with contrast. If their creatinine is too high to get a CT-IVP, then they can get a CT-KUB. And what you're missing there are very small renal masses and ureteral tumors, but those are very rare. So in general, gross hematuria not related to infection in women or asymptomatic microscopic hematuria, we'll talk about in a second, we need to see them. If a woman has an infection and hematuria which resolves, they probably don't need to be seen. And we decide on the role for looking in their bladder, although most of them will end up getting a cystoscopy. Now, asymptomatic microscopic hematuria, much more common. The definition of this can vary by lab. Some are greater than 3 red blood cells, some are 4. I think, as I said, if they have a positive culture, repeating the urinalysis in a couple of months is reasonable, with the exception being a man. And one common mistake, I think, is that just because you have a dipstick positive for blood, that doesn't mean they have red blood cells in their urine. So those people need just a microscopic urinalysis, and if there are no red blood cells, then don't worry about it. If you have red blood cells and you repeat the urinalysis in 3 months and you don't have red blood cells, does that mean you don't have to worry? Sadly, the answer is no. You still have to worry. So repeating a urinalysis, if someone has 4 to 10 red cells in 3 months and it's negative, doesn't keep you out of trouble if you don't refer them, sadly. Now, that said, what are the odds of someone with asymptomatic microscopic hematuria having actually some urological cancer? The answer is 2 to 3%. But almost all those people are smokers or solvent exposure, and those are almost all bladder cancers. So there's actually, now we've put these asymptomatic microscopic hematuria patients into risk groups, low, intermediate, and high. And some of the low risk groups, which is really young women or men who are non-smokers, no solvent exposure, and only have a few red blood cells, we're sort of holding off on cystoscopy in that group. They do get a CT-IVP. Sometimes we may just do an ultrasound, but it's not common. Most of these people don't fit into the low risk group. But again, less than 50 in women, less than 40 in men, a few red cells, no smoking, no solvents, then a renal ultrasound may be good enough. But that's sort of a decision for us to make. We talked about CT-IVP. In general, when we do cystoscopy or look in their bladder in the office, we always do something called a bladder wash for cytology. That's why you don't need to do voided urine cytologies. The bladder wash is a much more accurate test. So for hematuria, if their CT-IVP was normal, then we'll look in their bladder looking for small bladder tumors, which is what a CT-IVP can miss, and we do a bladder wash. And if their cystoscopy and bladder wash is negative, then they've been thoroughly evaluated. In general, the same is true for men and women. In men, if we don't find a cause, we usually write it off to the prostate. That's just by process of elimination. And then again, the next scenario that you run into is if your evaluation is okay, when do you have to recheck people? And there's no right answer to this one. But in general, if you have asymptomatic microscopic hematuria and you have a negative evaluation, you should have a urinalysis once a year. If you have to have gross hematuria, we need to see again. If you go from 3 to 10 red cells to 15 to 30 red cells, then we probably should recheck you. I would say the main mistake would be is not doing urinalyses on an annual basis henceforth. And then urinary catheters. This is a problem for all of us. My belief is that urosepsis must be a well-paid diagnosis in the emergency room, because every man or woman with a catheter or a urinary diversion who goes into the ER with a temperature has urosepsis. But in many of these people, that's actually not the cause. Almost all men and women with indwelling catheters are colonized. And it's a critical piece to understand the difference between colonization and infection. Colonization is normal. Symptomatic infection is uncommon. Catheters cause bladder irritation. Catheters cause bladder urgency. Catheters can cause urgency incontinence. That doesn't necessarily mean that you're symptomatically infected. Now, gunk in the urine, sediment, calcifications. These are all normal things to see in a catheter, tube, or bag. Does it mean they're infected? No. Does it mean they're colonized? Probably. So I know that even nursing homes have guidelines with this as to how people are treated. It's tough. I'll give you that. It's a tough problem. In general, though, with appropriate catheter care and management, it's uncommon for people to have symptomatic infections. Now, that said, there are some people where they get a change in mutation, especially the elderly, and you give them antibiotics and they get better. I can't argue with that. But you're treating their whole body. So whether it's a catheter or not, I don't know. But as I said, I struggle with this as much as all of you. Here are some tips. People who have long-term indwelling catheters are very commonly will get bladder stones, and they can definitely cause symptoms. So like in our spinal cord patients, we'll image their bladder every couple of years looking for stones. And if they formed a lot of bladder stones, we'll get rid of them and that's done through telescopes in the urethra, because they can cause more bladder irritability. Catheter bag management, there's this big thing now, it can't be on the floor anymore, but the bottom line is the further below the bladder is, the better you're going to drain their bladder. With small catheters, you'd be surprised, there's still sometimes 150, 200 cc's sitting in their bladder, even though the catheters drain into a bag. So the lower the bag is, the less urine they're holding in their bladder. If you're having problems with retention of urine with the Foley, you just have to increase the size. The VA has a rule where you change them every 4 weeks. I don't think that's a universal rule. It used to be 8 to 12 weeks. There's no right or wrong answer. Whether you do it every 4 weeks, 6 weeks, or 8 weeks, just depends. If the catheter changes every 8 weeks and it's pretty clean and there's not much junk on it, that's fine. I think a couple management things. If you're using a catheter with a leg strap, it's a good idea to change that leg strap either day to day or week to week from right leg to left leg. It puts different pressure on the urethra, so you prevent urethral breakdown, which is not uncommon. And again, leg bags versus overnight bags, you're always better with an overnight bag because it's hard to put the leg bag as low below your bladder as you can with an overnight bag. But that said, if someone's in a wheelchair and wants to wear a leg bag, it's going to be below their bladder. That's perfectly fine. What are some things that are done to prevent sort of colonization / infection? There's people irrigate their bladders with 0.25% white wine vinegar. Methanamine is a drug you'll see used to try to help prevent colonization. Daily antibiotics, either with macrobid or Bactrim. These are sort of late event things if people are really having symptomatic infections. And then sometimes you just irrigate their catheter every day with saline, but none of these things are easy. And the management of them, it's not easy to irrigate someone's catheter every day. So those are just things that can be done. Some other little catheter points. When you're going to get a urine culture from someone who has an indwelling catheter, the way to really do it is to pinch the tubing below. You can pinch it on itself and put a little piece of tape on and wait about 15, 20 minutes. And you can aspirate out of the port in the drainage tubing, not the leg bag tubing, but the overnight tubing. And that's the best with a sterile syringe. And that's the best way to do a culture. You should label it sterile cath urine for culture, not Foley catheter, because then they work up all the different bugs. But that's the best way to do it. Don't take it out of the bag. For guys or women that pull out or pull on their Foleys, such that they cause problems, this is actually a pretty easy fix. The standard catheter is a 10 cc balloon, but they make catheters with 30 cc balloons, and you can put 40 cc's of water in the balloon, and I guarantee you that nobody can pull that out. And if they do, you've done everything you can. It's a disaster if they do. I've never seen it happen. If you have a catheter and you're getting blood in your urine and it's blocking off the little ones, you can upsize them to a larger catheter. You can hand irrigate these if they need to periodically. We tell them to drink more liquids. You'll definitely see catheters clog up and they end up in the emergency room. That happens. In general, they need a bigger catheter. And then you always have to investigate why they're bleeding, because there may be other problems. So those people go through a good urologic evaluation. If a catheter falls out, it probably was because there wasn't enough put in the balloon. Some people only put 5 cc's in the balloon. That a woman could easily pee that out. A guy could almost pee that out. So in general, you should put 12 to 15 cc's of sterile water in a 10 cc balloon, which will keep it from falling out. Silicone versus standard. If they have a latex allergy, obviously use a silicone catheter. Other than that, there's really no difference. But you can always change if someone's having a problem with the latex allergy or latex problems, you can change them to a silicone. Another little pearl is for men or women on self-catheterization, where they catheterize themselves 3 to 4 times a day because their bladder doesn't work. For many, many decades, people would use a catheter for 2 or 3 weeks, wash it with soap and water, and then use a new one. And then about 10 years ago, they did a study in kids that showed that if you use a new catheter every time, you might lower their risk of infection. So the whole world adopted that, which was really pushed by the catheter companies. But in the last 5 years, it's been proven that that's been garbage. So you don't need one and done catheters anymore. It has no lower infection risk than reusing the same catheter for 3 weeks and then changing out. That said, you can't convince the one and done people that that's the case, but you can offer them as an option. So there'll be fewer catheters in the ocean if we do that. So with that said, let me stop and answer any questions.
I forgot my my reminder here. I had a question, if you don't mind, while we're waiting for people to identify their questions, and that relates to something that we hear concerns from older men about related to BPH and its treatment, as well as treatment for prostate cancer. And I've appreciated some of your reality checks and clarifications of common wisdom. I'm wondering about erectile dysfunction and BPH treatment and prostate cancer.
Are you talking about erectile dysfunction in conjunction with prostate cancer or as a separate entity in and of itself?
Well, I hear concerns about it in relation to treatment of prostate cancer.
Yeah. Okay. So that's pretty easy to cover. Let's focus on radiation and surgery. The bottom line is, if you have radiation or surgery for prostate cancer, odds are you're going to lose your erections. Now, you do maintain sensation of the penis. You have orgasm, but lose fluid emission. But you normally need some intervention to get a rigidity to allow for intercourse. And that's either a pump device or an injection. Viagra, Cialis pills can work in that population, but not commonly. Better in the radiation group than the surgery group. There are types of surgery that try to preserve erectile function. It can work. It's not that successful, except in very young men. But in general, that's one of the primary quality of life changes with treatment. Now, that said, there are a number of studies that have shown that if you have a couple that are interested in resuming some type of sexual activity that requires the man having an erection, that if they use a pump device, an injection, urethral tablet, they actually have a very reasonable quality of life compared to men who get their erections back. So I think that most commonly it's a couple-driven intervention, or I would say the likelihood of an intervention helping it will be based on the couple's goals. And then there are surgical interventions like inflatable penile prostheses and things like that, that can be effective. They're not the same as a native erection, but they certainly work. But in general, most men start with pills, low benefit, pump devices, or penile injections. Does that answer your question?
It does, but then also in relation to BPH.
Yeah, so there is a school of thought that BPH and erectile dysfunction are interrelated, and I'm not a big fan of that. I think they're interrelated because they both occur in men over 60.
Yeah.
And the question is, does helping your BPH make your erections better, or does taking Cialis or Viagra every day make your BPH better? and you're helping your erections and you're helping your BPH. I would just say that it's commonly done, but the benefits for BPH from taking a daily Cialis are not as much as you see with a placebo. And they have to be done, it has to be given in conjunction with Flomax or alfuzosin, not as a standalone drug. But there are men where, for some reason, there are some guys where if you make their urinary symptoms better, they'll say their erections are better. So there is a correlation there. It's just not a very strong correlation, no pun intended. But that's why you'll see some men with BPH pushing to get a daily Viagra pill or Cialis. Yeah.
That's helpful. So Mary is asking, what about men who self-cath 2 or more times a day, going to the doctor once or twice a year, having a UA, and then being treated for an infection at that time? Follow-up UA was negative, then a month later goes to see another doctor and repeats the same thing with treatment for UTI again. Prophylactic treatment with antibiotics?
So a great question. That's sort of getting to what I was getting at, where if you have someone on self-cath, you don't treat them unless they're having some change in symptoms. So for instance, in that patient scenario, you expect their urine to be infected. And if they say, no, I cath twice a day, I'm fine, I have no problems, you shouldn't treat them. If you treat them, sure, you'll make their urinalysis or culture get better, but that doesn't mean they needed treatment. Most of these men live symbiotically with their bacteria, or women. The reason they live symbiotically with it is that as long as their bladder's not getting overstretched, it's pretty uncommon to get sick from it. Now, if that patient who's on self-cath 2 or 3 times a day says, I'm getting a lot more bladder irritation, this isn't common for me, then a culture and treatment is reasonable. But if they're just routinely going in and getting one as part of their annual health maintenance, no, they shouldn't be treated.
So Beth is wondering, what are the long-term outcomes for neobladders in bladder cancer?
Good question. So a neobladder, for those that don't know, is where when you remove someone's bladder, normally the common approach is to bring their urine out to their skin with something called an ileal conduit, and they wear an appliance over it on their lower abdomen. For men and some women, you can create a bladder out of their ileum and sew it down to the urethra. I'll start with women. Technically harder. Most of these women will be incontinent. Many of them will need to do self-catheterization. But other than that, they've been around for 15 years and they tend to work pretty well. You can have bladder stones, you can have bladder mucus, all these things that need, evaluations and treatments. In men, the majority of men with neobladders have to do self-catheterization because they don't empty well. They can get problems with metabolic acidosis. They can have symptomatic infections, and they can have incontinence also. So in my opinion, having done hundreds and hundreds and hundreds of these both, it's a quality of life issue. If someone is really adverse to wearing an appliance, and it's not as common an adversity as you think, because they're dealing with something that they're going to die of in 3 years if they're not treated. And they're healthy enough to tolerate the additional surgical risk, and they're compliant enough to manage a neobladder, meaning they're willing to be seen frequently, they're willing to catheterize, they don't mind if they're as much as if they're incontinent, then a neobladder is perfectly fine. Do they have a better quality of life than someone with ileal conduit? Absolutely not. That's been well studied. So it's really just a personal image, personal preference concept in someone who's healthy enough to have it. But those are the main issues with neobladders. I hope that answered the question.
That's helpful. Thank you. Any other questions, folks? This has been a really sort of comprehensive, thorough discussion of GU issues, Dr. Dalkin, and I have appreciated your kind of dispelling, common thoughts as well as giving us the practical end word on some of these considerations. Very, very helpful.
Good. Thank you.
not having any other questions, I think we can close off for today, and we'll see you next week. Dr. Dalkin, thank you for this talk, important information, and I know that there's going to be people coming back to, as well as recommending the recording of this for friends and colleagues.
My pleasure. Take care, all of you, and thank you so much.
Thanks, everyone.